The respiratory system carries out several homeostatic functions. One of those primary functions is gas exchange, which happens between the atmosphere and the blood, which provides adequate supply of oxygen to your tissues and removes the carbon dioxide from the body outwards. This is going to tie into our second main function of the system, and that's pH regulation. Imagine now the balance between the oxygen and carbon dioxide is not happening the way it should. This is going to lead to acid-base disturbances and affecting your pH. We measure this by doing arterial blood gases, also known as ABGs. The next important function is protection. Protection from inhaled particles. We'll see here in another minute how the respiratory tract is lined by certain kinds of epithelial cells that trap allergens, dust, particles, organisms, and propagate them outwards because we don't want any of this substance going into our lungs. The only thing we want going into our lungs is oxygen, as clean as possible. The last one gets overlooked by a lot of individuals, and that is the lungs play a role with hypertension homeostasis. And that happens because the lungs have an enzyme called angiotensin converting enzyme, which converts angiotensin 1 into 2. So I just want you to know that very briefly. We won't go much into it in this chapter, but just know that there is an enzyme and there is a direct correlation with the respiratory system and hypertension. The respiratory system is divided into an upper respiratory tract and a lower respiratory tract. The upper respiratory tract consists of the nose, sinuses, the oral cavity, and the pharynx, also known as the back of your throat. As you move past the pharynx inferiorly, we reach an area called the larynx, which is the beginning of your lower respiratory tract. You go past the trachea. The trachea splits into a right and left bronchi. The right bronchi tends to be more narrow and wider. So if you ever get something that moves down into your trachea, it's more likely than not to get dislodged on the right side because of this anatomy. As you move past the bronchi, you divide into bronchioles, which divide even further into a primary, secondary, tertiary bronchiole, and into eventually the alveoli, which are the tiny air sacs at the ends of these bronchioles, which now we're in the lungs. So the lungs make up the last part of the lower respiratory tract. Now coming back to the nasal cavity, when we inspire air or inhale air, they come in contact with our epithelial tissues. And if you look closely at the very top, our epithelial tissue in the nasal cavity is lined by ciliated cells, which are tiny hair-like extensions, which help trap and propagate some of these particles that are in the air. As you breathe them in, they propagate them outwards because you don't want them going down into your lungs. And these can be allergens, dust, pollen, organisms, anything. So they're beating outwards. We also have in this epithelial tissue goblet cells, which are mucus secreting cells. You don't want our nasal cavity or our nasal cavity extending into the larynx and trachea being dry. So they keep this area nice and moist. We also have these little areas called glands, submucosal glands. They help produce little lubrication as well. And the last thing we see in these cells is vesicles, which house lysozymes. Lysozymes' primary function is to kill bacteria. As we move past the nasal cavity, we reach areas in our nasal cavity called sinuses. We have 4 paranasal sinuses: your frontal sinus, ethmoid sinus, sphenoid sinus, and maxillary sinuses, which are located right in our cheekbones. These are air-filled spaces. They help you warm and moisten the inspired air. They help you amplify voices. Imagine ever when you get sick and your nasal cavity and your whole face is congested with mucus. Some of these sinuses get plugged up as well too, and you can imagine how your voice changes. So this area, these sinuses are also kind of serve as echo chambers, and if they get plugged up, changes your voice. Also, the sinuses, they help you reduce the weight of your skull because they're just empty spaces, and regulate your intranasal pressures. As air moves past the nasal cavity, it reaches these little areas that are divided with grooves at the inferior. These are called the conchae. We have a superior conchae, a middle conchae, and an inferior conchae. The grooves below them are called superior, middle, and inferior just grooves or meatuses. And their primary job is air moves through these conchae and these grooves, not only warming the air, but also humidifying the inspired air. They're basically serving as filters. Imagine if these guys didn't exist and on a cold winter day, you just took in all this cold air. This whole cold air can cause bronchospasms of your trachea, or even up here in your upper respiratory tract, and eventually down into your lower respiratory tract. You don't want these bronchioles constricting because of that cold air. So these guys not only trap, they also moisten, they also filter and warm this air as it comes in. As we move to the back of the throat, this area is called the pharynx. If you inspire air from the nasal cavity and get to the back of the throat, we call this the nasopharynx area. From the mouth to the back of the throat, we call this the oropharynx. And if you extend just inferior to the oropharynx, we have another area which is at the border between the larynx and the pharynx called the laryngopharynx area. Now in this area, we also find our tonsils. There are 4 tonsils. Our pharyngeal tonsil, which you see right here, also known as the adenoids, the tubal tonsil, the palatine tonsil, which is at the base of the uvula right here, which is formed from the soft palate. And if you move a little bit more anterior to that area, you see the hard palate, which is more bony, and this forms the roof of your mouth. So hard palate, soft palate, the uvula, and at the end of the uvula, you have a little palatine tonsil. And the last tonsil we have here at the base of the tongue, posteriorly, is our lingual tonsil. Now, if you look at these tonsils with the mouth open, a couple of them you don't really see, but give you a general area where they should be located. They're more, you have to go a little bit deeper in the back of the pharynx and more superior. So here we just see this diagram right here. We see it from this area. So you really can't see up here. But this is a general area where you would have your tonsil, your pharyngeal tonsil, tubal tonsil. The palatine tonsil is the one you do see. You barely see it, but it's there. And if it ever gets inflamed, we will see a picture like this. This is inflamed tonsils. You can see the white stuff on there. There's some most likely bacteria, probably strep. And this is what we call tonsillitis, inflammation of our palatine tonsils. And here's the uvula. So the soft palate extending into the uvula. The uvula is important because it prevents food, liquids from going up into the nasal cavity from the posterior side of the pharynx. So the flap is kind of, preventing stuff from going up this way. So if you cough the wrong way, stuff can get up into your back of your throat, into the nasal cavity, and doesn't feel good, but eventually makes its way down. As you move past the pharynx, we get into an area right below that called the larynx. And at the top of the larynx, we have a little flap called the epiglottis. The epiglottis typically falls down and covers this area right here. When you swallow or drink something, this flap covers the trachea because you don't want liquid or foods going into the trachea, which is primarily involved with getting air into our lungs. So this flap falls down. And as we move further down the larynx, we have our trachea. And posterior to the trachea, we have an area called the esophagus. This is where all the food is going to go and eventually into the stomach. The larynx is mostly just cartilage and connective tissue. It connects the pharynx to the trachea, has a epiglottis, the flap that prevents food and liquids from entering the trachea, and also houses the vocal cords. Here you see closed vocal cords and open vocal cords, and this is why we call the larynx the voice box of the respiratory system. This area is also lined by epithelial tissue called pseudostratified columnar cells. They're basically just simple columns with cilia at the top right here. You remember the cilia we mentioned to help you trap and also propagate substances this way, because you don't want these substances being inhaled into the lungs. So this diagram, you can see 1, 2, 3 cells. They look like they're stacked. They would be just stratified. But the word pseudo-stratified, pseudo means falsely stratified, because this area is jumbled together. They're so compressed tightly that the cells kind of bulge on top of each other, giving it a false appearance that they are stratified. So really, if you just open this area up in the epithelium, then you will just see nice, simple columns. But they like to make it a little bit harder for you, so they call it the pseudo-stratified columnar with epithelial cells. And you don't see it in this diagram, but we also have mucus cells, which are, remember, mucus secreting cells called goblet cells, that also keep this area nice and moist. You don't want your trachea or larynx dried up. As we move further down, we reach the trachea. Trachea is lined by 16 to 20 cartilage rings. They're C-shaped. You can see the C-shaped blue area. These are cartilages. And this cartilage keeps the trachea open because you never want the trachea closed. Otherwise, you will not be breathing for very long. And at the posterior side, you can see there's a smooth muscle right here. This is called the trachealis muscle. So this muscle is just a mix-up of a tiny fragment of the whole circumference of the trachea. So this area, the cartilage keeps the trachea open. And in the innermost lining, you can see the epithelial tissue. You can see the little tiny hair-like extensions. So these are the pseudostratified columnar cells with cilia that also have goblet cells. This is a couple of times we showed you the epithelial tissue. So if I zoom in a little bit here, we can see the column-shaped cells that have the cilia at the top, and their job is to propagate substances and particles this way. So they're lined on both sides of the trachea, and they don't want any of these particles, dust, bacteria, organisms, allergens coming into the lungs. And you can see here we have a goblet cell as well. So pseudo-stratified columnar with ciliated cells. That's our epithelial tissue of the trachea. This area is also lined by our sympathetic nervous system, which includes our beta-2 adrenergic receptors. If we stimulate these receptors, we will dilate our airways. And then the parasympathetic system has muscarinic receptors located in the trachea and in the bronchi and in the lungs that will constrict our airways. One example of a drug commonly individuals know is albuterol, which is very commonly given for asthma patients. Those are called beta-2 agonists or beta-2 stimulatory drugs because they help you dilate the airways, primarily at the bronchi, where you have the main stems, or even at the bronchial level. As you move past the trachea divides into a right and left bronchi. These bronchi divide further into bronchioles and even more further into secondary bronchioles and then tertiary bronchioles, eventually making their way into the lungs. At the end of these bronchioles, you will see tiny alveoli, which are their air sacs, and you have millions and millions of them. But here we're just going to mention the lobes of the lung. The right lung has 3 lobes: superior lobe, middle lobe, and inferior lobe. The inferior lobe is also called the diaphragmatic lobe because it's right next to the diaphragm, which makes the base of the lung. And the top superior lobe is also known as the apical lobe of the lung. On the left lung, we only have 2 lobes: a big upper superior lobe and an inferior lobe. Here we can see a notch right here. This is where the heart is going to sit, and it kind of pushes towards the left side of the body. And this is called the cardiac notch. And because of that area and the heart pushing on the left side, the left lung only has 2 lobes. If we zoom in inside the lungs, we see these tiny air sacs called alveoli. And as I mentioned earlier, we have close to 500 to 600 million alveoli. And the primary job of the alveoli is to have gas exchange, oxygen into our cells and carbon dioxide out. And you can see the alveoli are lined by tons and tons of capillaries from the arterial system and venules, because you're dropping off these pulmonary arteries that drop off the carbon dioxide. They're kind of glued to the alveoli, and the oxygen comes in and drops off and carbon dioxide goes out. So imagine 500 million alveoli and how many capillaries, arterial venous system are glued to these guys, helping you deal with gas exchange. Now, if we zoom in a little bit more and look at this diagram of the alveoli, we will see a histological picture of these cells. Histology is just the study of the cells. So if you see the macroscopic picture here, you can see there's tiny air sacs, balloons. So when we look at the histological picture, we just see balloons right here. Here's one, here's another alveoli, here's another alveoli. And then you see areas where they're bigger alveoli, right here, the big little sac right here. This is what we call an alveolar duct. So majority of your lungs are lined by tiny air sacs, but then you have a few scattered bigger areas. Here's another alveolar duct. Make about 10 to 15, maybe 20% of alveolar ducts. So they're just mostly small air sacs and a few bigger air sacs repeating inside the lungs. Now, these alveoli, on the border of any one of these circles, we have a few cells you should know. Type 1 cells, which are your nourishing cells, and type 2 cells, which are very important because they produce surfactant, which their primary job is to decrease surface tension. So imagine when you inhale air, this balloon inflates, oxygen comes in, and then carbon dioxide is picked up, and then you exhale and this balloon gets smaller. Now on the exhale, these surfactant molecules, they push outwards on the alveoli, preventing it from collapsing too fast. This is their job. So when you have smokers that smoke a lot of times, that damages the surfactant on your alveoli surfaces. And as the surfactant gets damaged, you have 2 things happening. Alveoli get damaged, so these alveoli get converted into more and more alveolar ducts because the alveoli burst, and you lose surfactant, which decreases your surface tension, so there's a tendency for these alveoli to collapse. So imagine smokers now, say 10, 15 years of a life of a smoker. You can see how they're always gasping for air because their alveoli have collapsed, some of them. And they also have bigger ducts now, meaning less gas exchange. Imagine you have, on this picture, you have about, say, 20 alveoli. Imagine if these 20 alveoli now become, say, 2 alveolar ducts. You have less surface area for gas exchange. The 20 alveoli are doing a lot more gas exchange between oxygen and carbon dioxide than 2 big alveoli ducts. So smokers now will have a hard time getting air in and also hard time getting air out. And one of those long-term complications from smoking is a condition called emphysema. Emphysema can also be genetic, but if you look at this diagram compared to the normal diagram, you can see here's an alveoli. Here's a bigger one. But look at all the alveoli. They're a lot bigger generally than, you can see all these little tiny air sacs. This is just because those little individual alveoli are damaged and they led to bigger areas, meaning air is going to be trapped, and you also have ventilation perfusion defects.